When we were talking about skeletal muscle, we did mention that the skeletal muscle can engage in what is known as tetanus. Tetanus is sustained contraction. Complete tetanus is sustained contraction without any relaxation. Just imagine the dumbbell, curling the dumbbell and just holding that dumbbell there in a sustained contraction. That may be useful for some moments with skeletal muscle, but we absolutely do not want it with the myocardium. That is to say, we want the heart to beat, relax, relax, beat, relax, contract, relax, systole, diastole, diastole. We do not want the heart contracting and remaining in sustained contraction. If it remains in sustained contraction or tetanus, it's not doing two things. One, it's not relaxing and filling up with blood. And two, it's not pumping blood through the systemic circulation. So it is very, very important that the heart never engages in tetanus. If you think about tetanus and lockjaw, that's due to the botulinum toxin, and it makes it very difficult, dare I say impossible, for that individual to open their jaw because their skeletal muscle remains in a contracted state. But that's pathological. So how do we prevent this in the myocardium? Well, let's take a look at the excitation, the electrical activity of myocardial contractile cells. This graph of electrical activity is certainly different than anything we've seen thus far. We have a depolarization event and a repolarization event. Distinguishing this from other electrical activities in the body is this part right here, and this is known as the plateau phase. The initial depolarization event is due to sodium influx, and the repolarization event is due to potassium efflux. That's no different in most cells in our body. But there's an extension of the electrical activity or a delay in when it fully repolarizes, and that's due to the plateau phase, which is a result of calcium influx. So we get sodium influx to depolarize it. There's a slight repolarization up here due to some potassium efflux, but that stops. And then we kind of get a dribble of calcium moving into the cell to maintain this voltage up here. The whole purpose of this, which is known as the plateau phase, is to delay the repolarization of the MCC. Eventually, there's a large efflux of potassium, and then we get back to the resting state. So if we look at this in relation to the twitch we have in blue. Keep in mind the twitch, half of the twitch is contraction and the other half is relaxation. Once again, the twitch is mechanical activity, whereas in red we have the electrical activity. So what we see right here, we have the electrical activity happening. That's going to cause the twitch or the initiation of the contraction. In the plateau phase, because of the plateau phase, we see the electrical activity and the mechanical activity ending at roughly the same time, which means the myocardium cannot engage in tetanus. For review, if we look at a skeletal muscle fiber, this is the twitch, contraction and relaxation, and this is the action potential that initiates the contraction. Because this action potential is over just as the muscle starts to contract, we could have another action potential and then another one. We could have, let's say, based on this scale, maybe 7 or 8 action potentials even before that skeletal muscle starts to relax, which is going to cause a stronger force of contraction and potentially complete contraction, otherwise known as tetanus. We do not want tetanus in the myocardium. That's why we have this plateau phase. The plateau phase extends the electrical activity of the myocardial contractile cell to ensure that the electrical activity and mechanical activity happen at roughly the same time. Keep in mind, once a cell repolarizes, it can depolarize again. So this is delaying the full repolarization of the MCC. Now let's take a look at the myocardial autorhythmic cells, specifically the electrical activity of the myocardial autorhythmic cells. to be certain, the myocardial autorhythmic cells, if they engage in any force or any degree of mechanical activity or contraction, it is minimal. So for our purposes, we're going to just assume that MACs, the myocardial autorhythmic cells, are going to do nothing but depolarize and repolarize. So this is the graph demonstrating the electrical activity of a myocardial autorhythmic cell. It's going to depolarize, repolarize, depolarize, repolarize, depolarize, repolarize forever. And when I say forever, I am saying forever, your entire life. This is never going to stop. There is never a resting state. And I say it's never going to stop. It will stop if you have some abnormalities or issues with your electrical conduction system of the heart. But by and large, we should expect this occurring from the minute we are born to the minute we die. Let's say for 80, 90, 100 years if you're lucky. So let's see what allows for this to happen. So we have, and I'm going to show it right here, this slope right here, from this black dot to that black dot. We have that right here, from here to here. This is what's known as the pacemaker potential. Pacemaker potential here, and a pacemaker potential there. So we're starting at roughly 60 millivolts for our purposes. I don't know that that's super important. I just want you to understand what the graph looks like and what causes this electrical activity in the myocardial autorhythmic cells. Keep in mind, this is happening in the absence of any nervous stimuli. I am not saying in any way, shape, or form that myocardial autorhythmic cells never have nervous stimuli going to it, because they absolutely do, and we will talk about that down here. But in the absence of any nervous stimuli, this is the graph of a myocardial autorhythmic cell. And we're going to suggest, even though I don't have the units of time in here, that the myocardial autorhythmic cells are going to fire at roughly 80 to 100 times per minute. Keep in mind, I have said and I wrote times per minute. I didn't put beats per minute because the autorhythmic cells do not beat. They just depolarize and repolarize and depolarize and repolarize. And in the absence of nervous stimuli, they do so roughly 80 to 100 times per minute. I am fully aware that a lot of books are going to say 60 to 100, but I will explain in a moment why I'm suggesting it's 80 to 100. So this pacemaker potential is due to the opening of channels known as funny current channels. We have an I right here with a little f right there. F stands for funny, and in physics, a current is abbreviated or demonstrated with an I. So these are funny current channels, and when the researchers initially identified these channels, they noticed they were odd, dare I say funny, because something was happening they'd never seen before. Now, we've already talked about channels like this, and these are nicotinic channels. Now, to be clear, I'm not saying these are nicotinic, but what I'm about to describe is the same thing as nicotinic channels. That is to say, funny current channels allow sodium and potassium to pass through those channels. I suspect that these were identified before the nicotinic channels. Had they been identified after, the researchers probably wouldn't have found it that funny, amusing, or interesting. But it allows for the movement of sodium and potassium through the same channel. So why is it why is it depolarizing if both sodium and potassium are moving through the channel? It is because sodium has an electrochemical gradient favoring it to enter cells, whereas potassium only has a chemical gradient. And because of that, a lot more sodium is going to move into the cell than potassium leaves. And as a result, it's going to cause the cell to depolarize. Once it hits negative 40, that's what we refer to as threshold, and that's going to open up some calcium channels, causing this big spike right here. Then we're going to get the opening of potassium channels back down to negative 60, which reopens the funny current channels. So it starts depolarizing again up to negative 40, influx of calcium, efflux of potassium. back down to -60. It happens again. Funny current channels open with sodium and potassium passing through. Sodium wins that contest because of its electrochemical gradient. When we get to 40, we get the opening of the calcium channels, repolarization due to potassium, and that keeps going and going and going your entire life. And if you don't find that amazing, then I don't know what to say. So I have suggested, and I'm going to suggest once again, that this happens in the absence of nervous stimuli. I am not suggesting that the heart is always working in the absence of nervous stimuli. It can, because we have these autorhythmic or self-propelling, self-depolarizing cells that can do that without nervous stimuli. But that doesn't mean we always are absent in nervous stimuli. As a matter of fact, our baseline is probably parasympathetic activity, otherwise known as vagal tone, because of the vagus nerve. The vagus nerve releases acetylcholine that binds to muscarinic receptors on myocardial autorhythmic cells. And in doing so, it's going to slow down this rhythm due to roughly 60 to 80 times per minute. And that's why I'm suggesting without parasympathetic activity, it's firing, the MACs are firing 80 to 100 times per minute. With vagal tone, it's probably further down to 60 to 80 times per minute. So parasympathetic activity is rest and digest. We're chilling, we're studying, we're watching TV, and we have a diminished heart rate. And that's due to acetylcholine binding to muscarinic receptors, which are G protein linked receptors. And ultimately what that is going to cause to happen is to increase the permeability of potassium and decrease the permeability of calcium. Increase the permeability of potassium, decrease permeability of calcium. The P here represents permeability. So how would this look on a graph? Well, this is pretty much what it's going to look like. Keep in mind, this is due to increased permeability of potassium. The slope of the pacemaker potential now is not as steep as we saw here, and that's because of the increased permeability of potassium. It's now tending to counteract some of the influx of sodium. So once again, we talked about sodium and potassium are moving, more sodium comes in than potassium leaves, but now we're having more potassium leave than normal. Certainly, there's still going to be more sodium coming in than potassium leaving, but it's not going to be as extreme, and that's why this slope of these pacemaker potentials is flattened out. And then from here, from threshold at -40, by the way, it should take longer to reach threshold because of the increased permeability of potassium. From threshold up to here is going to take longer and have a more gradual slope because of the decreased permeability of calcium. Okay, now let's look at sympathetic activity. Sympathetic activity is due to norepinephrine or epinephrine binding to beta-1 receptors on myocardial autorhythmic cells, which is going to increase the permeability of sodium and increase the permeability of potassium. Once again, that's binding to beta-1 receptors. So let's take a look at this. Okay, so I realize there's a lot of things to follow here because I have 3 different colors, but to be clear, we are looking at the light blue one. The normal sinus rhythm in dark blue here has 1, 2, 3, 4 peaks, but our new rhythm in light blue has 1, 2, 3, 4, 5 peaks. Because the rhythm has been sped up due to the increased permeability of sodium and calcium. That is to say, the pacemaker potential from here to here is more steep in all cases down the line, because there's an increased permeability of sodium, which means now even more sodium is coming into the cell than normal and is offsetting that little bit of potassium that is leaving. In addition to it, this depolarization event is due to increased permeability of calcium, so it makes it up to positive 20 much more rapidly. So sympathetic activity due to epinephrine, norepinephrine binding to beta-1 receptors on MACs is going to increase heart rate. So this is going to be somewhere greater than 100 times per minute. Sympathetic activity is going to cause MACs to fire greater than 100 times per minute. In the absence of sympathetic activity, it's going to be 80 to 100 times per minute. With parasympathetic activity, it's going to be roughly 60 to 80 times per minute. The last thing I want to point out is the autonomic nervous system influences MACs as I've just displayed. Parasympathetic activity slows down the rate of myocardial autorhythmic cells, and sympathetic activity increases it. There is no direct parasympathetic influence on the myocardial contractile cells, but there is sympathetic influence. That is to say, epinephrine, norepinephrine binding to beta-1 receptors on MCCs will increase the force of ventricular contraction. To be clear, there's no direct stimulus by parasympathetic activity on MCCs. Since we're talking about the heart, we should probably discuss the medium through which things are flowing through blood vessels and through the heart, and that is actually the blood. There's roughly 5 to 6 liters of blood in human beings, and it can be broken down as follows: hematocrit, buffy coat, and plasma. To be clear, within the bloodstream, all this is mixed together, so it's not delineated this way, but if you were to put blood in a centrifuge tube, spin it, we would have the more dense components falling down to the bottom and the less dense components up to the top. So at the bottom, we have the percentage of red blood cells that make up blood, and that's known as hematocrit. So these are red blood cells, otherwise known as erythrocytes, and the main purpose of red blood cells is to transport oxygen to the tissues and away from the tissues. So it transports oxygen to the tissues. Oxygen binds to the molecule known as hemoglobin within red blood cells, and then it transports carbon dioxide away from the tissues to the lungs. Some of the carbon dioxide is certainly bound to hemoglobin, others directly in the blood plasma, and we'll talk about that as we move forward. So roughly 45% of our blood is made up of red blood cells, otherwise known as erythrocytes. This is variable depending on age and sex, but let's just say roughly 45%. Roughly 55% is made up of our plasma, and the plasma is primarily water, but it has ions, sodium, potassium, calcium, chloride, magnesium. It has nutrients like glucose, carbon dioxide, fatty acids, waste products. There's certainly gases within the blood plasma, oxygen and CO2. Oftentimes the plasma component is referred to as serum. Now the remaining component of blood, which is known as the buffy coat, is less than 1% of our blood. And that includes leukocytes and platelets. Leukocytes, otherwise known as white blood cells, make up our immune system, or the cellular component of our immune system, and platelets are involved with blood clotting. Books will describe erythrocytes, leukocytes, and platelets as formed elements because of the three, leukocytes, otherwise known as white blood cells, are our only true blood cell. And we say this because erythrocytes are anucleated, they have no nucleus, they have really no organelles, and really it's described as just being bags of hemoglobin with the intent of delivering oxygen and CO2 to and from the tissues. And platelets are fragmentary cells that are once again involved with hemostasis or blood clotting, and we'll talk about that in a subsequent video. So if you're trying to remember what's in the blood plasma, just know it's not red blood cells, it's not leukocytes or platelets. Everything else we consider as components of our blood plasma.